Hello, everyone, and thank you for joining the third annual SBC Working Group Virtual Forum annual meeting and our ninth annual meeting. As you join the meeting, please introduce yourself in the chat box. Tell us your name, your affiliation, and your country so we can see who is joining us today. For any new participants joining us, my name is Gabrielle Hunter, and together with Mariam Wamala Nabukenya, we are the co-chairs of the RBM Partnership to End Malaria SBC Working Group. We're happy to welcome you to the 2022 Virtual Forum. Great, I see several people introducing themselves. Please continue to do so. Okay, before we begin, I'd like to share a few logistical notes. First, please select your language for interpretation at the bottom right-hand corner of the screen. You'll see the instructions on this slide. Please go ahead and do this now. Next slide. You can follow along with today's presentation slides in English, French, or Portuguese by going to the link that is in the chat. And I believe on our next slide, we have the link also displayed. So once again, welcome everybody. Anyone joining us new today, my name is Gabrielle Hunter, and together with Mariam Wamala Nabukenya, we're the co-chairs of the SBC Working Group of the RBM Partnership to End Malaria. And we are also happy to introduce our theme of our virtual forum this year, which is Malaria SBC in Action. Next slide. And once again, please select your language. Next slide again. And lastly, the slides for those who would like to follow along in any language are available at the screen that you see here. Sorry, at the link you see here on the screen, as well as in the chat. And just a final reminder, our secretariat will send out all of the slides in all languages, as well as a recording of the event and a report of the event by email to everyone who registered for the virtual forum. Next slide. With that, I'd like to start the program for this two-day meeting focused on Malaria SBC in Action. Our agenda today and tomorrow reflects a wide range of Malaria SBC content on topics ranging from SBC for vector control to the RTSS vaccine and much, much more. Our theme this year reflects that every country's Malaria SBC action counts in the fight against malaria. And I just want to extend a special thank you now to everyone who submitted abstracts to showcase your important and impactful work during today and tomorrow's forum. Next slide. And finally, if you have not yet done so, please go ahead and introduce yourself in the chat box so that we can hear from you with your name, affiliation, and country. It's wonderful to see many familiar names and also a few new ones. During the meeting, all microphones will be muted, so please use the chat box for any communications that you have. Thank you. Next slide. So without further ado, let's go over today's agenda. You can view the agenda via the link that is shown on the slide here, which is also being pasted into the chat. Next slide. To start our meeting, we are truly honored that we will be able to begin with opening remarks from Dr. Corinne Karema, the interim CEO of the RBM Partnership to End Malaria. Next, we'll have a panel on SBC and malaria service delivery by Breakthrough Action and the USAID Integrated Health Program. After that, we will hear from the Zambia National Malaria Elimination Program on SBC targeting for IRS campaigns. Following that, this year, we are very excited to feature a new format of presentations. These are lightning talks. Lightning talks will allow presenters to speak briefly about the most important aspects of their malaria SBC work. It's similar to a poster presentation. Next slide. When we get to the lightning talk portion, all attendees will be invited to visit one of 2 lightning talk rooms focused on a specific theme. The first room will focus on malaria SBC at the community level. Next slide. And the second room will focus on reaching the unreached. And don't worry about making your decision just now about which room to join. We'll go over the titles of each presentation that will be featured in each room before opening the lightning talk sessions later today. Next slide. We'll now begin with the first session of our virtual forum, our welcoming remarks. Next slide. And before diving in, one final reminder, please select your preferred language using the interpretation button at the bottom right-hand corner of the screen. Please go ahead and do that now if you have not yet done so. Next slide. It is with great pleasure that I introduce our first speaker, Dr. Corinne Karema, the interim CEO of the RBM Partnership to End Malaria. Dr. Corinne Karema was appointed interim CEO of the RBM Partnership to End Malaria in April 2022. She previously served as special advisor to the board chair of the Global Fund and as the Malaria Senior Program Officer at the African Leaders Malaria Alliance for 4 years. Dr. Karema also served as director of the Rwanda National Malaria Control Program for 10 years, following 5 years as head of the Malaria and Other Parasitic Diseases Division. It's truly an honor to have her today. Please join me in welcoming Dr. Karema, and thank you for joining us. We're honored to have you share opening remarks for our 2022 virtual forum. Welcome, and the floor is yours.
Thank you, Gabrielle. And first of all, I would like to thank you, Gabrielle and Mariam, as well as the SABC secretariats for inviting me. And it's really an honor for me to be with you today. And on behalf of the Hold Back Malaria Partnership to End Malaria, I would like to welcome all the participants, as well as all the presenters and the steering committee. As you know, today we are at a precarious period due to the increase of malaria. Of course, we had, for the last 2 decades, we had progress in the fight against malaria, averting more than 1.7 billion malaria cases, as well as more than 10 million deaths. But as you know, for the last 2 years, we saw an increase of malaria with 214 million cases, and then more than 600,000 deaths. And it's really a big issue for us. We are off track because we wanted to, there are some targets that we wanted to achieve, and especially in Sub-Sahara. We all know the current challenges that we have. There is the COVID-19 impact, and there is also low malaria intervention coverage. And this is where I see the importance of the SABC working group, because it's really important that with the current tools, we need to increase and improve the usage, as well as the compliance of our communities that are affected with malaria. And for us to get back on track, we need to tailor the malaria response to local settings. We need to strengthen, of course, our health system and ensure that we get global malaria funding. But the most important is, while waiting for the innovation as well as development of new tools, it's really important that our communities use the current malaria control and intervention. And this is where I really welcome this meeting, because I'm sure that we are going to discuss how to improve and effective malaria control intervention, and as well as how our communities can comply, and then so that we can get impact on malaria. And then that's why I really value this working group as well as other working group. And this social and behavioral change is really an important strategy for us to end malaria. And with that, I would like to thank you for inviting me. And we are together, and wish you all the best. Thank you.
Thank you very much, Dr. Karema. And I know that the team out there was looking forward to hearing from you. And from what you have highlighted clearly, we are off track. And I know that countries appreciate that we are off track. And we also have low coverage of interventions. And we need to put ourselves together to discuss issues that will move us forward. We want to take this opportunity to thank you so much for honoring our invite and for taking social behavior change as one of the most important in the fight against malaria. And as you're aware, that we are so much highly dependent on human behavior to see the malaria get out of all these countries that we are targeting. So with that, I would like to use this opportunity to thank you. And I know everybody out there is excited that you've been on this call. We really thank you so much. The team here compiled a few questions with the team out there that we would like you to look at and try to throw some light for us to appreciate that we have a very big problem, and we want to understand your perspective of and your view of how important it is for us to see malaria get out of these countries. So I'm going to open this session to a few questions to you, Dr. Karema, and I hope you will be able to answer to these questions. Of course, I know that you will. My friend Gabriela and I will I'll take a question on, and Gabriela will also take the other. So my question to you, Doctor, is how can malaria SPC professionals advocate for social behavior change funding, especially within the programs where they sit? And as you're aware that we have the Global Funds as one of the leading funders for countries, how would you see the programs and professionals advocating for funding?
Okay, first of all, it's important to note that the funding gap for the malaria response is still low. So if we look at the 2021 World Malaria Report, a total of $3.3 billion US was invested globally in the fight against malaria in 2020. However, to reach the global malaria targets, annual investment needs to be more. It needs to triple by 2030. So at least to have roughly 9 to 10 billion per year. And you know that last week we had the Global Fund replenishment. The Global Fund is one of the important funding mechanism with the Presidential Malaria Initiative. And with the Global Fund, the target was 18 billion US dollar, and we were able to get only 14.25 billion. So we are already in a constraint and limited funding space due to all other competing diseases as well as priorities given the impact of COVID-19. So it's true that although we have limited funding for the malaria response, it's also, I agree that the funding for SABC is really not appropriate, not adequate. And we usually see that the SABC program are underfunded. And while we all know that SABC are really important and are needed for us to, first of all, achieve high coverage of all the malaria control intervention that exists, as well as SABC's use also to convince and then sensitize and mobilize community to use new tools as well as the existing resources that we have for the fight against malaria. So the first for me, I think that the first action should be to have an SABC as a strategy in all national malaria control strategic plan. So this is, the SABC should be seen as one strategy, as case management, as prevention, as surveillance. So this is number one. So at least SABC one, when integrated within the malaria strategic plan, this will also bring attention and then get it funded within the malaria strategy. So this is number one. Number two, what is important is, do we have a SABC strategy that is updated, and how is, for instance, this working group advocates for SABC to be put at a high level on the agenda, for instance, for all the key funding mechanisms. I know that in PM, for the Presidential Malaria Initiative, it's really very important, but is it important for other funding mechanisms? So this is one, and then this needs to be also prioritized. So I think it's really important that SABC be seen as a strategy. When I say seen as a strategy, this needs to be with clear activities as well as a clear M&E component that will help us to track the impact of SABC in all our strategic plan, as well as globally in the global malaria response.
Okay, thank you so much, Dr. Karema. And if I can re-echo, of course, I can't finish everything, but what is very important for all of us who are on this call is that we need to take SBCC within our countries as a core intervention, and we have it as a core objective within our strategic plans. And so we can use that to continue advocating for more resources. And we have had an opportunity to interact with over so many program managers this year through the country coordinating mechanism of RBM, the country regional support partner committee. And we have also raised it so seriously at that level that social behavior change should be a very important intervention. And we hope that the donors have heard. This will not stop, we will continue advocating until the resources, but we also want to appreciate our dear CEO that even if we are presenting this issue, the resources have continued to grow slowly by slowly. So we really want to appreciate you, and we use you as our key advocate to continue getting resources. Let me call upon my colleague Gabrielle to take us through the other set of questions. Gabrielle, you're welcome.
Thank you, Miriam. And echoing Miriam's thanks for those insightful remarks around how we can all do more to advocate for funding. So for our next question, Dr. Karema, we wanted to ask you to reflect maybe a bit more internally on the workings of the working group and how it connects with other working groups. So we'd like to hear your thoughts in thinking about the value that each technical working group contributes to RBM. What collaboration and coordination would you like to see across them? And if you have any points specific to our working group on that as well. Thank you.
Yeah, thank you, Gabrielle. So first of all, The technical working groups are part of the RBM architecture. It's really very important that it's like a family. So we are together. Technical working group are really important, and the RBM Secretariat, we value the technical working group contribution, especially in all the global malaria response. And technical working groups are part of the RBM architecture, as I say. I personally see technical working group as I see committees, partner committees, as I see the secretariat, and we really need to coordinate and work together for us to achieve the strategy and the objectives of the RBM partnership to end malaria. So this is number one. Number two is it's true that there is need to improve coordination within technical working groups, and then also to improve collaboration as well as relationship with the RBM secretariats, as well as the committees, the partners committees. So I think this is a really very important for us to be able to combine all our efforts to accelerate the fight against malaria. So in terms of collaboration between different working groups, next month, we are hosting a meeting with all the technical working groups, so to try to see how we can provide a forum where all the different working groups can sit together, can talk together, and then this is where we can also see what are the synergies, what are the area of collaboration. And of course, SABC being, for me, it's really a core technical working group that should collaborate and work with the other working groups, because other working groups are more on the different strategy as well as intervention that we are using to fight against malaria. So I see that it's really important that you both collaborate and try to see how you can even integrate some activities. So in terms, for instance, of sharing best practices for countries, I don't think that a country or a partner will present the implementation of an intervention in a district without mentioning SABC, because without, sorry? Yeah, so I think it's really important, and that is why we are hosting a workshop in October with all the technical working groups co-chairs, so that we can sit and see and discuss on how better we can improve our collaboration, and then how we can also combine the effort. Thank you.
No, thank you so much for those remarks. I think you've given us some good food for thought as we think about the future of our working group, which will be a session we will discuss tomorrow during this forum. And we also thank you so much for creating that platform for the technical working groups to meet next month. We certainly will take advantage of that very valuable opportunity. This is helpful advice, and really great to hear about the vision of where the technical working groups stand within the RBM family. That's quite wonderful and heartening for us to hear about the importance of our working group connecting not only with the other working groups, but also, as you mentioned, with the partner committees and the Secretariat. So we will continue to make those concerted efforts. Well, once again, thank you so much, Dr. Crema, for all of these points that you've given us. You've given us some direction, you've given us some energy for our deliberations for today and tomorrow. I'm not able to see the chat, and I'm not sure if there may be questions in there from members, but if you have a moment, feel free to to interact and respond to any if there are there. And once again, thank you for taking the time to join our virtual forum. It's truly a pleasure to have you.
Thank you very much for the invitation. Thank you.
Wonderful. I think we want to get our slides back up again. Before we dive into our technical presentations for today, just wanted to recognize and thank the SBC Working Group Steering Committee. Next slide. Our steering committee includes not only myself and Miriam, whom you've already met from the Uganda National Malaria Control Program, and myself from the Johns Hopkins Center of Communication Programs as co-chairs. We also have a number of members who you see here on the slide. We have Angela Acosta with the Johns Hopkins Center for Communication Programs, Avery Avocados with the US President's Malaria Initiative through USAID, Shelby Cash, also with the US President's Malaria Initiative through the CDC. We have Deborah Freitas Lopez with the University Research Co., Tonga Mafuleka of the Malawi National Malaria Control Program, Naomi Cervantes with the US President's Malaria Initiative Tanzania through USAID, and Ibrahima Sano of the Guinea National Malaria Control Program. Just want to take a moment to thank all of you on the steering committee for your tireless work to advance the malaria SBC agenda and maintain the momentum of our working group over the last few years, especially during this highly virtual time. Next slide. I would also like to introduce, welcome, and thank our Francophone and Lusophone ambassadors. They include Jemima of Madagascar, Mori of Mali, Ida of Burkina Faso, and Ibrahima of Guinea. And Jean-Jacques Brou of Côte d'Ivoire is the Francophone point of contact. You can contact the Francophone ambassadors by selecting the ambassadors tab of the RBM Springboard page, which is being posted now in our chat. Our Lusophone ambassadors include Sergio of Mozambique and Suzy of Angola, and Deborah Freitas Lopez is their point of contact. You can contact the Lusophone ambassadors by joining their WhatsApp group, and that link is also going into the chat now. And a big thank you to this network who has done so much over the last 2 years to reach out and grow our membership and connect us across linguistic groups. So thanks so much for all of your support. Earlier this year, both of the ambassador groups hosted Francophone and Lusophone networking sessions for the SBC working group, which we found very fruitful. If you attended one of these sessions, please let us know in the chat now. We'd love to hear from you. Next slide. I also want to introduce and thank the Secretariat for their fantastic work planning this 2022 virtual forum. The Secretariat includes Ashley Riley, Eva Rosen, and Jean-Jacques Brou of the Johns Hopkins Center for Communication Programs. They are based in the US and in Côte d'Ivoire. They have done an incredible job putting this program together for us. And finally, we thank everyone who joined our planning committee for the virtual forum. This came from members of the steering committee, ambassadors, Secretariat, and from the members themselves. So thanks for your help to prepare for today and tomorrow. I'll now pass the floor to Ashley from the Secretariat for an important announcement about our upcoming steering committee elections. Over to you, Ashley.
Thank you, Gabrielle. And next slide. Next slide, please. Thank you. First, I want to thank the steering committee for their incredible leadership over the last 2 years. Terms are ending for our co-chairs, Gabrielle and Miriam, as well as Naomi, Tonga, Deborah, and Angela. Thank you again for your great leadership over the last 2 years. Elections are guided by our terms of reference. According to our terms of reference, both co-chairs can run for a second term. For steering committee members, There are no term limits. As long as they meet the criteria for eligibility, they can run again. This is all described in our terms of reference. Nominations begin today and go through October 14th. Please find the link in the chat for the nomination form. It's also on the slide. This will be shared by email after today's event. If you are interested in running for a position or nominating a colleague, please review our terms of reference for eligibility requirements. It's available on endmalaria.org. Please contact the SBC Working Group Secretariat with any questions. Next slide. Now we will move into our several malaria SBC technical presentations. I will pass the floor to Shelby to introduce our first panel. Next slide, please.
Thank you so much, Ashley, and hello, everyone. My name is Shelby Cash, and I'm a member of the RBM SBC Working Group Steering Committee and also co-lead of the PMI SBC team. I'm very excited to be with you today and also very pleased to welcome Abdel Agadazi of Breakthrough Action and Canberra Collective and Yusuf Siraj of the USAID Integrated Health Program in Nigeria to speak under the first panel theme of Malaria SBC for Service Delivery. As Abdel and Yusuf present, please share your questions in the chat. And after both have completed their presentations, I will moderate a question and answer session based on the questions from the audience. Next slide. With that, please welcome Abdel on segmentation of ANC clients for the prevention of malaria in pregnancy. Next slide, please.
Thank you, Shelby. Hi, everyone. Welcome to this presentation where I'm going to share the work that we did over the last year on segmenting ANC clients and share with you some of the early results that we found. If you can move to the next slide. So last year we conducted a study to really try to understand what are the opportunities, but also barriers for women to go to ANC facilities, but also to stick to IPTV-SP treatment. And we leveraged the malaria behavioral survey that has been conducted across several countries. And we especially used the data from Côte d'Ivoire, Cameroon, and Malawi. That gave us a pretty large sample size of 14,000 women. And then we narrow it down to really focus on the women that had a live birth over the last 2 years. And by combining these three countries, we were able to pull a sample size of 46 women across these three countries. And the goal for us was really to build a segmentation that where we were really trying to see if we could have a segmentation that was applicable across these three countries and see if the barriers, needs that were driving women behavior in coming or not to ANC consultation and taking IPTP or not were also present across the three countries. If you go to the next slide. So the first, maybe to share a bit of the context about malaria in pregnancy. So it's a concern, especially for pregnant women that have like an increased risk of up to four times more at risk of getting malaria when they're pregnant, but also an increased risk of dying from malaria. So today, malaria in pregnancy is still responsible for 20% of stillbirth, 11% of newborn death, but also more than 10,000 maternal deaths. And malaria in pregnancy can not only affect the mother during the pregnancy with complication for the pregnancy, but also the child outcome during the pregnancy, but also later with development or poor developmental behaviors that can come also later on in the life of the newborn. So narrowing down the behaviors for these women so that we can manage and have like the right messages for them so that they can come more often to the facility to seek ANC services, but also they can come earlier to the facility to seek ANC services was really critical to be able to address this even earlier in the pregnancy as well. Should we go to the next slide? And to be able to conduct our segmentation analysis, we focused on three key outcome variables and behaviors that were interesting for us. So the first one was really to try to understand what were the behavior of these women in terms of like how many times and how many checkups they attended during the pregnancy. So in the malaria behavioral survey, we had several variables that enable us to assess each of these points. So there were a question that actually asked the woman how many checkups they attended during the last pregnancy. So that was really helpful for us to assess and classify the women across that specific behavior. The second one we were interested in was really to understand the quality of the services at the facility when the women came to have an ANC consultation. So that was the second outcome variables. And then the last outcome variable were really focused on IPTP and SP. And we were trying to understand how many times they took the preventative medicine during their last two pregnancy. So we use these three outcome variables really as drivers to see what are the subgroups across the population of pregnant women comparatively to each of these three outcome variables. Next slide. And the approach we use is that first, we try to understand what are the key drivers of the women behaviors across these three outcome variables in trying to understand the key needs, attitudes, and behaviors. So we run some chi-squared tests between the outcome variables, but also between the other variables in the data set to really start to understand what are the key correlations between the other variables to see what have an impact on the woman behavior. And then after that, we use these key drivers to really build the segmentation and come up with segments that I will present in the next slide with you. And then in the second time, if you can come back to the previous slide. Yes, thank you. So in the second time, we build a prototype of a counseling tool. So once we have defined the segmentation and the segments, we really build and prototype a counseling tool so that we can enable providers at the facility to have all the tools necessary first to identify which segment a woman belongs to across the different segments that we identify, but also to have like specific counseling cards for each segment so that they can have like targeted messages for each of the women at the facility. Next slide. So the analysis to identify what are the subgroups across the population give us 5 segments. So we identify 5 segments across the data set of the 3 countries with very specific behavior and very specific barriers to attending ANC or taking IPTP treatment during the pregnancy. So the first group that we call the active modernists are the women that have conversation with their husband and they're quite well aware of the benefits of ANC. And they tend to go to ANC quite early and as many times as required during the pregnancy. And they also think that all other women in the community are also doing the same. They are quote unquote the women that have the targeted behavior across the 5 segments that you have identified. And they are quote unquote the best in class across the 5 segments. And then we also identify a second segment that we call the unhurried informed. So similarly to the first segment, they also are aware of the benefits of ANC and they think that it's useful for them, but they are not in a hurry. So for them, the key barrier is really attending to the ANC consultation early enough in the pregnancy so that they can follow the treatment path completely, but also take the IPT completely. And the other thing about the unhurried informed is that they're not completely convinced about the benefit of IPTP during the pregnancy for them. And then we have a third segment that we call the cautious moderate that tended to have close discussion with the husband or the spouse, such as making the decision together of going to ANC visit or not. But for them, the key barrier is really about being aware of the risk of or the increased risk of malaria for pregnant women. So the awareness of the risk was lower comparatively to the other 5 segments. And the other key characteristic for this segment is that they think that other women in their community are not going to ANC visit, which also tend to affect their own attendance of ANC counseling. And then we have the last 2 segments that we qualified as the most vulnerable. So first we have the uncertain new mothers. So they tended to be mostly single mothers. They don't have much experience with ANC counseling. And the key characteristic for them is that their experience with attending previous ANC counseling have not been as satisfying as the other 5 segments. And then the last segment that we call the vulnerable and aware, for them, one of the critical characteristics is that in terms of decision-making in the household, the partner tend to generally make most of the decision, especially the one of going to ANC counseling or taking IPTP medicine. So we came up with this segment by conducting the quantitative analysis, mostly leveraging a latent class approach, and we added the quotes really to personify each of the segments. So we didn't conduct any qualitative analysis in a sense, but the quotes are really here to explain and help see what is the woman behind each of the segments. We go to the next slide. So building on the segmentation, so the key there were 5 key factors that we identified, and some of them were more salient for some of the segments. So the first one is really the spouse and partner influence, where we think that there's an opportunity to change the behavior of the woman, especially for vulnerable and aware, where the partner is mostly the one making the decision. So there's an opportunity to do more male engagement to really change how partners are involved in the decision of women going to ANC counseling or not. But also there's an opportunity with cautious moderates who have discussion with the partners, and it's not necessarily the partner making the decision, it's more of a joint decision. But then there we think that by influencing and engaging the partner, we could increase and improve the women attendance of ANC. And then there, for the last group and the last segment, is the uncertain new mothers who usually don't have a husband or a partner, and they don't come usually with a spouse to the facility, who is already put them in a marginal position, because most of the facility will tend to promote women that come with their husband or partner. The second characteristic was the social norms. So women perceiving what other women in the community are doing regarding ANC or IPTP. And for that, the cautious moderate and the unhurried informed tended to believe that other women in their community are not necessarily attending ANC or taking IPTP and SP. So there is an opportunity there to really change their perception of their community in order to enable them and maybe push them further to also attend, and maybe leveraging role models such as the active modernist segment to really for them to really dispel their belief that other women are actually not going to ANC as well. And then the third one is really the trust in ITNs, but also the trust in the treatment, which are really separate. But we saw that the 2 trust issues were prevalent across for the vulnerable and aware segments, where they tended not necessarily to believe that ITNs could be beneficial, and they also tended to be skeptical regarding the treatments and drugs that they could get from the facility. And then the fourth one is the perception of health workers, and that one is particularly present for uncertain new mothers who recorded the lowest satisfaction scores for the previous ANC counseling. And we think that it can also be due to the fact that most of the time they go to the facility without a spouse. And then the last one is the perception of the risk of malaria, who is really prevalent for the cautious moderate, who tended to underestimate the risk of malaria, and which is one of the factors why they're not in a rush or in a hurry to go to ANC counseling. And after building the segmentation, so we developed a counseling tool that we tested a couple of weeks ago in Malawi. And during the pre-testing of the tool, we also identify additional factors that influence the behavior of these women by having the discussion with several health workers that conduct ANC counseling. One factor that came out of this conversation was the fear of the unknown. So women not necessarily willing to share their pregnancy status within the community, especially as they think that in the first trimester, if they share publicly that they are pregnant and the pregnancy did not go through, it can have like an influence. So they tend to hide their pregnancy status, and it's also one of the critical factors why they're not going to the health facilities. And then we also uncovered other factors such as the traditional religious beliefs, especially regarding IPTP and how it can impact their pregnancy and health, but also the incentives for ANC attendance. So some women coming to ANC counseling, or at least a first ANC counseling, to be able to receive free ITN, but also some women coming up at the first ANC visit just to be able to get their name registered for the delivery date, and then they don't come up again until the delivery date itself. And then the last ones are really the fear of side effects, especially for IPTP, but also some literacy that were also shared as a potential factor for impacting women attendance of ANC or not. Next slide. So maybe a bit more about the counseling tool that we developed. So it's a tool that we have developed in other health areas as well, where the tool is really separated in two parts. So there is a counseling, a providing tool part, where using a set of questions, the provider can really identify which segment the client belongs to, but also specific counseling cards with specific messages, for each of the segments. And the way the tool works is that it's a set of cards that is used by the providers at the start of each counseling session. And then the provider goes through the profiling tool quickly to identify the segment of the client, and then goes directly to the specific counseling card to really guide an empathetic conversation with the client. And the tool is a very useful tool in terms of enabling the provider to better understand the background and what are the limiting factors for each client, and have a more tailored approach to the counseling regarding malaria messages. But also it helps provider focus on the most relevant factors for the woman. And another feature of the tool is that it's quite easy to scale, especially in low resources context, because it's a tool based on paper. You just need to print it out in several copies to be able to deploy. And we pre-tested it in Malawi to see how providers were reacting to it and using it in live counseling sessions. And if you go to the next slide, I can share a bit more about that. Next slide. Thank you. So when we conducted the pre-testing in Malawi, so providers were able to use the both side of the tool. So the providing tool that you can see on the left, where we have a set of questions that's it's a structure as a tree, a decision tree, actually, where we ask a first question to really ease the conversation, and then a set of definite question to really help us classify the woman. And then on the right, we have the for each segment a specific counseling card. Next slide. So the pre-testing was give us a pretty strong result in terms of satisfaction from the health providers. The first outcome of the pre-testing was that each of the segments that we came up with was recognized during the pre-testing by the providers. Providers were actually able to share with us live stories of women that they had in counseling session that matched some of the segments that we share with them. And the second feedback also was that in terms of using the tool, we ran several rounds of role plays, and in the second round of role plays, providers were able to go through the tool and the counseling session in even approximately 10 minutes, where with more trainings and habits of using the tool, they can actually go through the tool much quicker, and it can actually be an opportunity for providers to accelerate how they go through ANC counseling sessions and actually improve ANC counseling sessions in the long run. And it was also well received by the representatives from the NMCP, the MOH, and the reproductive health department as well that were present, and they expressed really will to actually pilot the tool. And another opportunity that they wanted us to continue pursuing is actually using the tool, because when we using the tool in the community setting, the tool was initially built and designed for facility setting, but we actually saw that there could also be an opportunity in the community setting to really target some of the segments that were reluctant to come to the ANC session. So in terms of next step, we're really at that phase of exploring what could be the next step for the tool in terms of testing it out in the community setting, but also piloting it at the facility and scaling it at the facility as well. So that's in a nutshell the study that we conducted. So thank you so much.
Thank you so much for that insightful presentation, Abdel. Please continue to share your questions for Abdel in the chat. Next slide. I would now like to pass the floor to Yusuf Siraj of the USAID Integrated Health Program, who will lead us through his presentation, From Facility to Community: Provider Behavior Change Improves Reach of Quality Malaria Care in Northern Nigeria. Welcome, Yusuf.
Yeah, thank you so much, Shelby. I hope I'm actually being heard loud and clear. My name is Dr. Yusuf Siraj. I work for USAID-funded Integrated Health Program, and I'll be taking you through the presentation on facility to community provider behavior change improves reach of quality malaria care in Northern Nigeria. Next slide, please. So the goal of USAID-funded IHP. Oh, I know you can go with the next slide. I think I'm done with this. Please proceed. Next slide, please. Can you hear me? All right. So by way of introduction, I will say that the goal of USAID-funded IHP project is to reduce maternal and child morbidity and mortality in supported states. And we all know that malaria is one of the leading causes of morbidity and mortality among children under 5. So IHP is currently implementing the project in Kebbi, Sokoto, and Bauchi, and we have also expanded to Ebonyi and FCT. One of our core mandates is actually capacity building of health workers, mostly on site, including lab scientists and technicians, as well as routine facility mentoring and supervision. IHP is currently working towards improving adherence to the National Malaria Case Management Guideline, which states that all cases of fever should be tested with MRDT or microscopy, and that all confirmed positive cases, which is termed uncomplicated, should be treated using ACTs. The EQA there is an acronym for external quality assurance, and the EQA strategy in particular strengthens the quality of malaria diagnostic services to minimize misdiagnosis, overdiagnosis, inadequate and inappropriate treatment, and drug resistance, thereby improving malaria case management. Next slide, please. Yeah, so to give a quick overview of IHP in Kebbi, I would like to start by saying that it is a state with an estimated population of 5.278 million. And based on the last NDHS in 2018, malaria prevalence in Kebbi is 52% and is the highest in the country as at yet. The Kebbi State has 21 local government areas and 225 wards across the 21 LGAs. And IHP is currently supporting 1 PHC per ward across the 225 wards, which means we are having a statewide coverage across the 225 wards. In addition to that, we are also supporting 1 general hospital in each of the 21 local government areas. We are also supporting some additional 20 private facilities to ensure that we have the private sector involved in improving the health system at large. IHP also works through 5 embedded offices in the states to take the implementation closer to the facilities and mentor them more frequently, which is one of the key mandates of IHP to ensure that their skills are properly maintained. Next slide, please. Yes, so for the next slide, in April 2019, that was actually when IHP commenced operations in Kebbi State. And some of our findings during our baseline assessment, it's actually some of the things that you can see as the situation analysis. One key thing that we noticed was that there was high clinical diagnosis, that some of the health workers tend to treat malaria without diagnostic confirmation and base their diagnosis to history they are hearing from the clients. There's also indiscriminate prescription and administration of ACTs and the use of other anti-malaria, which is not the standard. As mentioned in the policy, it is expected that all uncomplicated cases should be treated with ACTs. There was also poor skills around how to conduct MRDT in line with the national guidelines or with the guidelines of the kits. This is also a major challenge that usually causes a lot of false positives and negatives for clients, and that may actually affect the data and the care that the clients are getting. In addition to that, certified malaria microscopists were limited, and only about 8 of them were trained as at then and certified in the state. Next slide, please. So talking about the intervention strategy, to begin with, IHP engaged a short-term technical assistant consultant to coordinate and institutionalize the EQA in the state. Like I mentioned earlier, EQA is external quality assurance. And the institutionalization of EQA system in the state kick-started around September 7th to 8th through the review and approval of the EQA guidelines in the state. There's actually a national guideline for external quality assurance. This was actually reviewed and adapted for the state, and it was actually signed and approved by the Commissioner for Health on behalf of the governor of the state. The secondary facility baseline assessment was also conducted, and this was actually followed by a rapid capacity development of the existing EQA officers, the 8 of them I mentioned earlier, by the consultant based on the outcome of the baseline assessment, which shows some of the gaps they were having in conducting microscopy in their respective facilities. We also institutionalized quarterly on-site monitoring and mentoring by the trained EQA team to address the identified gaps from January 2020 till date. And in addition to that, there actually was a capacity strengthening and certification of EQA officers through the basic malaria microscopy training in Lagos. This was done in collaboration with Waterreach, who are usually the host of this training, and they are the one that gives certification to laboratory scientists to become certified malaria microscopists. This was particularly informed by the first quarter EQA, which was conducted with the initial EQA team that had the rapid capacity building by the consultants. Now, after this, we continued with the quarterly dissemination of findings to the state stakeholders and partners from January 2020 till date. This is part of the protocols of the EQA, which involves visiting the facilities to ensure that things are being done correctly by applying some checklists to identify gaps, and then disseminating these identified gaps to the stakeholders to identify key challenges that they may actually have to address to ensure that malaria microscopy is actually done in the correct way. Finally, after the dissemination of findings, there is usually a participatory development of quality improvement action plans based on the gaps that have been identified in the assessment. Next slide, please. Yes, so this table actually shows a detailed breakdown of the intervention at secondary facility level. I will just run through this to save time, as most of the important aspects have been mentioned earlier. The first column is basically talking about the review and approval of EQA guidelines, SOPs, and job aids in the states. These are already existing nationally. They were just adopted, reviewed, and then approved for use in the states. The second column talks about the training in Lagos, which I've already mentioned earlier. And part of the objective of the training was to increase the pool of certified microscopists and to institutionalize EQA quarterly in the States by the EQA team, which were actually formed in line with the guidelines and based on the outcome of the training that was conducted in Lagos in collaboration with Waterreed. The third and final column is talking about the identification of an EQA center, which was actually innovated by the states, and it was equipped with the support of PMI to serve as a dedicated lab to EQA in the states, and for the EQA team to meet, plan, validate, and view slides for the quarterly EQA. This is part of the process of quarterly EQA implementation in the states. They will actually need to meet, plan, and discuss on how to implement the EQA for the quarter, and then they do validate slides and also view slides from facilities that are supposed to be archived to ensure that what they are viewing in the facilities are actually correct or not, and appropriate corrective measures are taken. Next slide, please. The table here is focused on the PAC component of the intervention. This is because there is a little difference between the protocols in the primary healthcare centers and that of the secondary facility. Primary health centers are expected to actually focus on MRDT because they do not actually have the prerequisite and the requirements and skills and qualification needed for accurate malaria microscopy. And that is why the microscopy is strictly left for the secondary facilities to implement. The first column is actually talking about the MRDT quality assurance checklist and job aids for MRDT, because even the conduct of MRDT has some quality checks that needs to actually be adhered to ensure that it's correctly done and the correct results actually obtained. The second column is about capacity building, which was conducted to improve the skills of the conduct of MRDT among PAC workers, also to address some of the gaps we identified during the baseline as mentioned earlier. So we actually have the magnificent low-dose high-frequency training, which is an on-site skill-based and data-driven training of all health workers across the 225 supported IHP facilities on malaria case management, malaria diagnosis, and malaria prevention. And at the end of the day, we had about 926 health workers trained to improve their understanding of the standards of malaria case management, diagnosis, and prevention. In addition to that, we had the LGA malaria focal persons who are already identified and working as the focal persons in charge of malaria at the LGA level. They were also trained separately on MRDT quality assurance and how to apply checklists to mentor facilities on MRDT, provided that, of course, all those facilities have been trained. So they were also trained now to follow up and use the checklist to ensure that they're actually working with the training that they were given. There's also continuous mentoring of the LGA MRDT QA officers, both physical and remotely, using WhatsApp application to ensure that they implement their mentoring plan as scheduled. And the third column is actually talking about each MRDT quality assurance officers identifying MRDT QA center in their LGA for better coordination. So just like we have a state EQA lab, we expect that every LGA should actually have an MRDT quality assurance center where they can also sit down and plan on how to improve the quality of MRDT conduct in their local government. Next slide, please. Yes, unfortunately, that is not looking so sharp, but this is actually a cascade chart. And for malaria cascade, like I was mentioning earlier, the national guidelines to test all fever cases and treat all cases of confirmed uncomplicated malaria with ACT. There are some key terms there that we need to be conversant with, which is confirmed uncomplicated. Confirmed means that the test is positive. Uncomplicated means it is not a severe case. And the standard treatment identified is ACT. Any other thing outside ACT for all complicated malaria treatment is actually not the standard. And then ideally, all those who actually have fever should be tested with RDT to be sure that it is malaria or to confirm that it is really not malaria. So based on this, the National Health Management Information System, NHMIS, has selected indicators to track this performance of facilities to see how they are able to meet up with this criteria and guideline. And as you can see, we have the cumulative data from the chart from 2018 to 2021 for the purpose of comparison. And if you look at the chart, you see that for persons with fever and those tested with RDT, there has actually been a persistent gap, which is mostly due to supply issues. You can see that from 2018 to 2021, there's definitely a gap between those lines. They're actually supposed to be equal or close if all those that are tested actually having fever. And in addition to that, the persons with confirmed uncomplicated malaria treated correctly with ACT is obviously above 90. You also agree with me that the lines showing confirmed uncomplicated malaria and those that are actually treated with ACT actually appears to be merged, and that shows that it is way above 90%. The clinical diagnosis, which is actually one of our interests, because it is a wrong practice and is the target behavior change among health workers that we are trying to achieve. It is highly, it's slightly elevated, through 2018, 2019, and 2020, and it actually peaked around the Q4 of 2020. It is evidently low from 2021, Q2 to Q4, when the EQA was fully established and has remained very low since then, which is an evidence that there is some degree of behavior change among the health workers towards clinical diagnosis. Next slide, please.
Yusuf, sorry to interrupt. I just want to ask you to slow down a bit as you're presenting for our interpretation to be able to follow you. Thank you.
Okay, thank you so much. That is well noted. So the next slide is for the results. And for the results, malaria quality of care is said to be achieved when all fever cases are tested and all confirmed uncomplicated cases are treated with ACT. This is a WHO standard and is in line with the National Malaria Guideline. Like I mentioned earlier, the key point here are that every case of fever requires testing, and every tested person that comes out positive without signs of complication is said to be confirmed uncomplicated case, and such a case should be treated only with ACT, and any other treatment is not a standard. And this is actually one of the key things that IEP is working towards achieving. And the indicators for measuring malaria quality of care as captured in the previous slide. And in the previous slide in the charts, you can see all the indicators that are captured there are basically number of people with fever, number of people who are actually tested, number of those who tested positive, number of those who are confirmed uncomplicated, and number of those who are treated with ACT. So by and large, the confirmed malaria cases from the data has actually decreased from 2019 to from 282,533 to 176,307 in 2022 in primary health facilities in Kebbi State. The large number, I believe, could actually be linked to the incorrect diagnosis or clinical diagnosis, because at then, most of the diagnoses were clinical diagnoses without confirmation, and that may have actually explained why we have a large number of people being positive. And moving forward, we believe that with the change of behavior towards confirming diagnosis before treatment, it has actually improved the number or reduced it as the case may be. The positivity rate also declined. Actually increased from 89% in the Q4 of 2018 to 92% in the Q4 of 2021. Reduction in this gap is indeed a marker of improved quality of case management, which is what we have actually been pushing for, and is also in line with some degree of behavior change among the healthcare workers. Next slide, please. Yes, this slide looks a bit clearer. So this is actually a graph that is showing some of the outcomes and assessments of our EQA across a period of time. So the slide shows malaria diagnosis performance as assessed during EQA after the training has been conducted. And the bars you can see is basically comparing the baseline findings with findings of Q1, Q2, and Q3 of 2022, when the EQA has been fully established and functional. You can see that there is a significant improvement for all the elements assessed when compared to the baseline, which is the first value you are seeing in each group of 4. The elements that are being compared and assessed include the documentation in the laboratory testing space, water supply to the lab, laboratory safety practices, including waste management, general laboratory supplies, including some of the ingredients and things that are used for microscopy, then the commodities stock out, like basic consumables like injections and gloves. We also have lab staff training. We also have blood film preparation, which is a stage in the malaria microscopy process. We also have staining and examination, and quality assurance, which is ensuring that the quality of what they are doing is actually correct. So these are basically the items that were assessed during the EQA period with the checklist. And obviously, you can see that compared to the baseline, there has been significant improvement across all of the elements that have actually been assessed for EQA at the general hospital level. Next slide, please. Yes, so with this, we are coming to a conclusion that dissemination meeting and continuous quality improvement plan that are developed quarterly by the state stakeholders are key strategies employed towards changing attitude of clinicians on both malaria microscopy and MRDT results, and addressing health worker practice and behavioral determinants such as attitude towards MRDT, skill competency, and self-confidence through on-site training and mentoring in their own work environment was effective in improving provider adhering to malaria SOPs and ultimately resulting in improved quality of malaria diagnosis and treatment. We so much believe that with the institutionalization of the EQA system and the training that was conducted, the healthcare providers now have an improved attitude and behavior towards accepting the result of MRDTs, that the microscopy that is coming to them, and of course, reducing on the inappropriate clinical diagnosis that they were actually doing in the past. And with that, there has been a lot of improvement in quality of care for malaria in every state. Thank you so much.
Thank you so much, Yusuf, and thank you both, Abdel and Yusuf, for your insightful presentations. Both of these presentations have highlighted the important aspects of malaria SBC for service delivery. And now we want to move on into the question and answer session of the presentation. And so for the first question, this is from Mark Loacatere. Congrats on the presentation, and this question is for Abdel. This is a very important tool. Do these profile segments also consider those mothers who are hindered by geographical barriers, for example, distance from facility or transport insufficiencies, as well as those mothers who've had many births and feel experienced not to attend ANC or the recommended number of visits?
Thank you for the question. I think in the MBS survey that we used to conduct the analysis, so there were like questions that helped us control each segment regarding the number of births that the woman previously had. So we didn't saw any strong correlation with the woman behavior with the number of previous births that they had before. To answer that first question. And regarding the distance and the more external factors that could also influence them coming up, I think so these elements were not covered directly in the MBS survey, so we were not able to actually see what influence this could have. So we really focused on the behavior aspect and more intrinsic attitudes and perception of needs, but also perception of what other people were doing in a sense. If that answers the question.
Thank you, Abdel. This next question, or actually two related questions from April Monroe and Blessing Ajayi for Abdel. You mentioned that there were some groups of women who may be less likely to go to the clinic or who may start ANC services late. Do you see the adaptation of the tool for community health workers as a way to reach those women? And are there any other approaches you're considering for reaching those segments? Or are there some ways to target them in communities by community health workers?
It's a great question. I'll say yes. So when we pre-tested the tool, so when we were designing the tools, we designed the tool to be used in the facility as the bulk of the segments in terms of like proportion within the population, I think were coming to the facility at least once. But then we had like these two most vulnerable segments, so the uncertain new mothers and also the vulnerable unawares, who even as they represented a smaller proportion of women, they are more likely to come later to the facility during their pregnancy. So when we pre-tested the tool, I think the feedback was from the NMCP as well, was that it could be interesting to adapt the tool to be used in the community so that for these specific women, when they are pregnant, we can identify them earlier. So there were like this mechanism that exists, for example, in Malawi, that's called like the secret mothers, who are women within each communities that have like the trust of other women and who are more likely to know when a woman is pregnant. So adapting the tool so that these women could use it and conceal these women and incentivize them to go to the to ANC much earlier during the pregnancy is one of the ways that we are exploring. And then there's also other ways to really target these women by leveraging other channels of communications and leveraging potentially other programs and other community programs that exist. As I was saying, the tool is quite easy to scale. It's just a really paper-based tool, and it's quite also easy to train people on that have some familiarity of doing community activities. So we think that it can be easily adapted and easily train people that are already present in the community so that they can easily identify these women in the community. And then we can start providing them ANC counseling and IPTP treatment much earlier in the pregnancy.
Thank you so much, Abdel. I apologize. This next question is for Yusuf from Dr. Nunu Ken. Thanks, Yusuf, for the comprehensive presentation. Could you please elaborate more on the point on data discrepancies between lab record and health facility medical record? Thanks.
Yeah, thank you so much. I want to still try and speak a bit slower. Can you just go to the previous slide? As for documentation, if you look at this graph, you notice down that documentation, the baseline is extremely, in fact, almost across all the elements, the baseline for documentation appears to be the second lowest. And that is basically because most of the facilities are really not documenting what they are doing, which was actually one of the things we observed. And the EQA, as you can see, subsequently, there has been exceptional and very impressive improvement in the documentation in the laboratory areas. So in the initial situation, most of the facilities were not documenting their own laboratory services, and only few that were doing it were not really doing it correctly. And that was the essence of having the EQA team going around to do some of the mentoring and guiding them on what they need to do. In addition, I had actually mentioned earlier that IHP are implementing an embedded office system so that our technical staff can have access to the facilities more frequently. And that was actually one of the ways we have used to actually address that. So there has usually been a lot of discrepancies between the laboratory consumption and utilization with the HMIS register. In addition to that, the clinical diagnosis I had mentioned was also a gap for those who are actually providing the services, apart from those that are actually doing the testing. So that has also led to some discrepancies because sometimes somebody is not, some clients are not even tested and they're already treated for ACT. So you see in the register, a client is treated for ACT and he wasn't even tested in the first place. Or a client is tested and it's negative and then somebody still goes ahead to treat again with ACT because he doesn't have trust on the MRD. So there are discrepancies and we have actually tried to use the mentoring to improve on that. And as you can see on the graph, the documentation have actually.
Thank you so much, Yusuf. Can we also advance to the question and answer slide, please? Great, thank you. So this next question is also for Yusuf from Larry Ngasa. Which approach have you used to improve health worker practice and behavioral determinants in CQI interventions? How much can it be applicable for a specific risk community?
Well, the CQI has to do with quality improvement, and we actually have another section of quality of care that we're actually implementing, and that actually has several indicators, including malaria indicators, and it was actually really helpful to support the facilities to see their performances over time and the need to improve on that. So most of the facilities were trained on what we call the quality of care and quality improvements, including the processes that are required to ensure you use data to guide what you are doing and also to assess your performance at every point in time. And I must say that was quite effective because it's being pasted on their board or their shoe board, and everybody could see how they are performing on a monthly basis after analyzing their. Sorry, okay, I think I was muted. Can you hear me now?
Yes, Yusuf, we can hear you.
Okay, fine.
Okay, great. Well, those are all the questions that we have time for at this moment. Thank you, Abdel and Yusuf, and to all. There's also a request from Elizabeth Chayende for Abdel. Can you share the counseling tool being used? Perhaps that's something, Abdel, you can respond to in the chat. And if there are any other questions that we have not been able to answer during this session, we'd like to ask Abdel and Yusuf to respond to those directly in the chat. And with that, I will now pass the floor to Deborah Freitas Lopez to introduce our next topic.
Hello, everybody. My name is Deborah Freitas Lopez, and I am a Senior Director and Lead for the Global LAC in West Africa region at URC. I am also one of the steering committee members, and I'm glad to be here with you today. Next slide. I'm pleased to introduce Pauline Wamulum of the Zambia National Elimination Program. Her presentation considers how using spatial intelligence can improve SBC targeting for indoor residual spray campaigns. Pauline, please remember to speak slowly for translation purposes, and welcome, and the floor is yours. Next slide, please.
Thank you. Thank you, Deborah. I will switch on my video so that you're able to see me. Thank you for giving Zambia an opportunity to share some of the lessons related to IRS acceptance and how Zambia is investing in spatial intelligence to make smarter decisions in terms of SPC. And this innovation actually helps in ensuring that it gives you a better understanding in terms of the visual information that is critical for us to make important decisions in ensuring that there's acceptance of IRS. So thank you so much. Next slide, please. I think I've more or less talked about what this presentation is all about, and it's all about making smarter decisions or working towards smarter spraying of our structures in our country within the realm of indoor residual spraying thematic group. Next slide, please. My presentation basically will look at the flow of data, malaria data, and the importance that the program has given this particular area. as well as the collection of SB data as it relates to IRS and SBC visualization, recent trainings that have been conducted by the program, and we'll share with you some feedback that we got from our participants, as well as some plans moving forward and next steps that actually stipulates in terms of how the lessons that we have learned as a country will help other colleagues that are having challenges with indoor residue spraying in terms of acceptance. Next slide, please. So as earlier alluded to, Zambia has for a long time been investing in data generation, and we've conducted malaria indicator surveys since 2008, and this information has actually given us impetus that malaria elimination is possible as long as the data is being generated, you have the evidence. And this slide shows you the areas in Zambia that have low malaria cases or low burden areas. So the lighter colors that you see on the slide are areas in the southern province of Zambia where the cases are low. And the darker places are what we call the high burden areas or provinces within the country. Next slide, please. Again, just to emphasize the importance of malaria data generation and also the flow of this data being timely from the community level up to the health facility level to ensure that we make timely and appropriate decisions that ensures targeted or data-driven interventions. And this applies to SBC as well. I want to mention that I think in the past, we have not really invested much in generating SBC data as compared to the other thematic groups such as case management. But then there is a deliberate effort by the program to begin to invest in generating data across all the thematic groups, SBC inclusive. And that's why we are here to share with you one innovation that we have embarked on having started in 2021, last year, that is. Next slide, please. Just to share with you that we recently developed our national malaria elimination strategic plan for the next that is going to guide the implementation of malaria interventions in the country for the next 5 years. And this particular document was launched last month, the last week of August. And it focuses on a number of issues that are important for malaria programming. And so the focus really is on tailoring how, when, and where we apply our proven interventions to accelerate reduction of malaria, and also to look at coming up with malaria-free areas in communities that have low local transmission, and most importantly, strengthening the flow of malaria information, ensuring that there's regular collection, analysis, and also visualization of SBC data. And I must mention here that the malaria program has made a decision to profile the SBC thematic group as a main intervention area or main intervention, as opposed to SBC being a cross-cutting intervention. And so that decision has been made, having realized the important role that SBC plays in the entire realm of the malaria program, knowing that the uptake of interventions and also the acceptance of IRS will not be optimal if SBC is not implemented appropriately and effectively. Next slide, please. So in investing in SBC as well as the spatial intelligence, using spatial intelligence, Zambia is putting this particular innovation into practice, beginning with the indoor residual spraying. And we envisage or expect to improve IRS coverage using real-time monitoring of the spray team service delivery. And also just to indicate that in 2021, that last year that is, we added some SBC questions to an activity that is always undertaken soon after the IRS campaign. And this activity of adding some SBC questions and asking household members post-IRS was done in 7 districts of our country, mainly in the southern part of Zambia, where you see the red, as well as the western province of Zambia. And interestingly, the results were used to visualize malaria exposure, malaria message exposure, for example, and as well as comparing where you have high refusal hotspots, and as well as availability of some communication channels and other structures that could be used for possible community engagement. Next slide, please. And so this slide, I'll share with you some of the key results. So an analysis of the responses showed poor malaria message penetration in areas with limited radio, where community engagement failed to take place, and where households missed IRS due to travel for fishing or any other reasons. And there were 76,000, over 76,000 eligible structures across the 7 districts. Of those, 4,900 were not sprayed, and that is a significant number. Some of the reasons that were advanced or given for not spraying included an adult not being present when the spray teams visited the household to spray. Secondly, the house having been locked, and also household illness, or a household having an individual or a child or a family member that is ill, and also just not wanting to have their house sprayed for no apparent reasons at all. So again, just to mention that refusals accounted for 42% of structures not being sprayed, and that is about 2,090, so it's slightly over 2,000. The largest reason a household was not included in the IRS campaign included the following, which we felt that is actually important to share. Fear of the chemical. Household members were not very sure whether the chemical is safe for them. The inconvenience of the intervention, and by inconvenience, we are talking about, the household members having to move household items in readiness for the spraying. And so this was one of the reasons why household members refused to have their houses sprayed. And number 3 was the belief that IRS is not safe. It's just, not safe. You're spraying a chemical, therefore it's not safe. And so the responses were visualized by color-coded maps to identify gaps in service delivery. Next slide, please. So this map, I'll introduce you to the legend. So where you have the gray area, that's the settlement, where you have, villages and so on and so forth. And then you have the health facility. And this particular district is called Sinazongwe district, and it's in the southern province of Zambia. And you do recall I mentioned that there are areas that have low transmission that are low transmission areas, and southern province is one of them. And so this is where Sinazongwe is located. And when it comes to the clusters, it's really clusters of poor message exposure, meaning no malaria message recall in the past 6 months. The yellow dots that you see represents houses or surveyed households or homes where SBC questions were not asked for one reason or the other, or due to time constraint mainly. And so when you look at the red dots, they represent the degree or the level of refusal. So where the bigger the red dot, the higher the refusals. So this particular map is able to show where the refusals are high and where the refusals are low. And with this kind of visualization, then you are able to make decisions in terms of where to take your resources, or where to invest your resources in terms of SBC. Should you take it to an area that has, high refusals? And it also gives us some other structures that are around that particular area with high, low, or medium refusals. Next slide, please. So again, it's the same location, but looking at IRS in depth and really delving into the actual refusals. So again, this map, it shows where SBC questions were asked, and it overlaps with limited messaging penetration. And reasons for refusal, again, as earlier mentioned, are layered over the map. You are able to see where you have the specific barrier or reason why an individual or a household member actually refused to have their house sprayed. So what we are trying to understand is that refusing to have your house sprayed is not enough. It's not going to help the program to target our messaging, to identify our target audiences, to select our communication channels, and so on and so forth. But if we know what builds up to the refusals, then we can isolate and better, address that particular barrier with an appropriate SBC intervention. And when you look at the legend, right at the bottom, the colors are, yellow, purple, and so on, but really they represent the different types of refusals, fear of chemical. So with this map, you are able to see where fear of chemical is a big issue. You are also able to see where bedbugs are an issue, and so on. And this actually is going to help the program in crafting or developing effective messages that actually tackles that barrier. Next slide, please. This particular slide is similar to the ones that I've shared, but looks at Gwembe district, which failed to reach the IRS threshold of 90% coverage due to high refusals. So with this kind of information, derived from the IRS program, as an SBC entity, we are then able to delve into what actually led to Gwembe district, for instance, not being able to reach the 90% coverage. And the reason cited was high refusals. So with this spatial intelligence, we are then able to get granular and look at what are some of these barriers within the realm or the subject of high refusals. And then I just wanted to mention that when you look at the red dot, you can see that there are a number of structures around where you have high refusals. So there is a community school, for instance. There's a place of worship, which is the Seventh-day Adventist. And there are some boreholes where women gather to draw water. And all this information is actually very important to give us insight and also to make decisions in terms of how we reach our population in an area where there are high refusals. Next slide, please. Again, it's a similar slide. I won't really spend much time, but just to indicate that I did mention that this particular innovation was done in Southern and Western Province. So with Western Province, this is a picture of a district called Denkeyema. Again, you can see where we have high refusals and where the refusals are low. Next slide, please. And so as I was going over the map, just to emphasize that this area of Gwembe shows coverage of below 90%, as Ellie alluded to, high refusals as one of the biggest reasons. And I think I've mentioned that it also identifies schools, churches, and other areas that can serve as entry points around IRS and other malaria messages delivered by a trusted messenger. Next slide, please. Again, you will agree with me that engaging our gatekeepers is very important. And in our program, we do take community engagement as a very important component of our programming or SBC. And this particular slide just goes to emphasize that for us to increase uptake of IRS and to increase coverage, we need to ensure that we use effective channels. And having engaged some of our communities, we actually do get feedback from some of our district stakeholders and as other key stakeholders across the country. And this particular one really emphasizes the importance of involving the headman, for instance, as you can see on this is a quote saying, implementing IRS last season, we did not engage the traditional structures very well, so we experienced some refusals. In one of the villages, the headman was the one mobilizing, telling people to have their houses sprayed, and the acceptance was good. So these are some of the key lessons that we have learned, and also we want to carry forward as we prepare for our next campaign, which was actually launched yesterday by our minister. Our campaign will run from the 26th of this month up to the month end of November. And so we are taking the community engagement very, very serious. Stakeholder involvement is also very key. Next slide, please. just to share with you some pictures of our participants that attended the IRS training in August, and these included our district and health personnel interacting with the SBC visualizations. And we feel that it is important for our spray operators to be able to also have an idea in terms of where we have the high refusals as they are making decisions in terms of this spraying campaign. So next slide, please. Again, just to emphasize that sharing these maps is also very important with our frontline workers who actually are responsible for delivering this very key vector control intervention. Next slide, please. So just to share with you some SBC mapping feedback from our training participants. I'll not go through all of them. I know that the presentation is going to be shared. I'll just pick on two that are very key. So I'll go to the second bullet, which says that, and this is feedback from the training participants. So it says that precisely, so the mapping, the SBC mapping, precisely shows places with higher refusals and reasons as to why they refused, which is very, very important for us in the SBC family. And also, if you go to last but one, it also says SBC mapping is able to show the real picture of what happens in the community and to rethink how social mobilization is conducted. Very, very important for us. Next slide, please. Having learned from 2021 and also having realized that there were some questions that were not asked, moving forward, we would like to ensure that we collect additional questions, and these questions will be compulsory. And also, we hope that it's going to feed into having a robust data set around barriers to IRS. And we hope that having that data or data set around barriers will help us to better implement our SBC in trying to improve acceptance of IRS. And also added to that, we will be collecting phone numbers or mobile numbers of the household members to allow for a post-spray spot checks, so that we kind of interface with individuals that may have refused and begin to kind of interact with them to find out exactly why they refused and so on and so forth. And also just to indicate that, the new survey questions are going to include showing the respondents an image of one of our posters that we have been printing for some time now and distributing to the districts as a way of raising awareness. And we would want to find out whether the household members or community members have seen this particular poster, and if they have, where did they see this poster, and if at all they are able to recall the message that is on the poster. And as you know, most of the programs, I think, do actually invest in printing of posters. And we feel as a program that it's very important to kind of gauge whether this is a good investment, or is it adding any value? Should we be looking at other channels of communication other than the poster? So starting this year, we will have some questions around the poster that we've been using. Thank you so much. We can move to the next slide, please. In terms of the next steps, and I think I'm concluding, I will be concluding. I just wanted to mention that from our perspective as a program, and when I say as a program, it's the EC or the NNEC and the partners collectively. So the findings from this approach can actually help to tailor messages and activities, and also to identify who can be a good messenger to address a specific barrier. You remember I talked about the water points where there are high refusals. So water points are frequented by women mostly when they go to fetch water. And that's an area with very high refusals. So should we be using these water points as opportunities to interact with our women and share information around IRS, particularly about the fear of the chemical and all those barriers that I shared with you earlier. And also, we are hoping that for better understanding of the local context, as well as SBC data, we need these to be layered with other data points, such as malaria cases, radio signal coverage, chiefdom boundaries, cell phone tower locations, and any other infrastructure that is there that can be useful to our work. And so in summary, I would like to say by adding the spatial perspective, countries like Zambia can actually detect patterns of SBC delivery, coverage, and also mount a tailored data-driven response to address specific barriers by tapping into local structures and appropriate communication channels. Next slide, please. Next slide, please. So from the landlocked Zambia, I would like to thank you for your attention. And I would like to also make special mention of Derek Pollard, as well as Todd Jennings, for having put up, taken up the time to come up with, to work with us in coming up with this presentation that I hope other countries can learn from. Thank you so much.
Thank you, Pauline, for your presentation. We have many questions. So what we will do is we will address a few now, and Pauline can address any that we don't have time for in the chat box. So the first question is from Mark Lacater. Sorry if I misspoke your name. With regards to SBC exposure, did the data link with which media source was less prevalent or correlate with setting type, urban versus rural, to understand which media source is relevant or preferable per setting? Over.
Thank you very much for that question. And I think maybe just to mention that there are additional questions that we are planning to add to the list of the two, so that we can begin to answer some of those critical questions. But again, just to mention that the districts that I shared with you are actually located in the rural parts of Zambia. And so in the rural parts of Zambia, the main source of communication would be the community radio stations, but again, reception is not as good. And so hence the need to look at the other communication channels or other opportunities, as we shared in the presentation, such as the schools, the churches, and so on. I'm not sure if I've ably answered your question.
Okay, thank you very much, Pauline. We have one other question from Neural. Great visualization, Pauline. May I know the reason of fear to chemicals? was their sharings of any bad experiences that caused this reason or any local beliefs that influenced the refusals?
Thank you, Deborah, and thank you for that question. Yes, routinely we do collect this information soon after the spraying campaign, as earlier mentioned, which runs from for a period of almost 2 months, starting the 26th up to the 27th. It's usually the same period every year, and questions are asked. We actually have a data collection verification form, which is a tool that is used to collect data. And in terms of refusals, fear of chemical, relates to household members feeling that the chemical may harm, the children within the household, and also the experience of having come into contact with the chemical. Some people have shared that they actually experience skin irritation. And so when this information filters in the community, then it begins to give the program, the IRS program, that negative aspect in terms of promoting the intervention. So it's really the skin irritation. There's some, especially those that have reacted, asthmatics, for instance. There are 1 or 2 people that have mentioned that they have, difficult in breathing, for instance. And when they share this information, then it builds that fear within the community about the chemical, and hence the importance of delving into some of these barriers for us to be able to craft appropriate messages.
Pauline, one more question from you from Joseph. Do you involve provincial administrators like chiefs to address refusal in the community? Who are the mobilizers in the areas with high refusal rates?
Thank you for that question. Yes, we do involve what we call community volunteers. In some places, we call them community mobilizers.
Hello, Pauline? Oh. I think we lost Pauline. And so we'll ask her to respond to this question via the text, via the chat box option. Those are really all the questions that we have time for today. Thank you so much, Pauline, and thank you everyone for your fantastic questions. These are great. Pauline, we hope you can address these questions via the chat. There are questions about bed bugs and how quickly you were able to react and respond to the data. And now I will pass the floor to Gabrielle to introduce our next topic. Thank you very much.
Thanks, Deborah, and thanks, Pauline. I'm sorry that we lost you there near the end, but do hope she's able to reconnect to respond to some of these other questions. So our final agenda item for today is a new type of presentation. Sorry, can we get the next slide? Thank you. We've got a new type of presentation for our group called Lightning Talks, and we're excited to try this new format. Lightning Talks are a chance to quickly learn about the malaria SBC efforts that our members have been working on throughout the last several years. The talks are 5 minutes each, followed by a short question and answer session. So it's a fast-paced, brief presentation on the main messages of the work, in a lot of ways similar to a poster presentation. Because we have such a large number of presentations that came through in our abstract submissions, these lightning talks are divided into 2 rooms by topics. You will be free to choose the room you're most interested in attending today. All of the lightning talk slides and recordings will be shared afterwards. So you will also have the opportunity to listen to the presentations in the room that you did not attend today. Next slide. Here are your two options. The first lightning talk room is on malaria SBC at the community level, and the presentations in this room include the impact of community level SBC interventions on malaria behavioral determinants within a large-scale integrated health SBC program in Tanzania, SBC for the integrated delivery of ITN and SMC during the COVID-19 pandemic in Zamfara State, Nigeria. Step back, how can nets work better for the village sleeping arrangement? And using the role model approach to explore caregiver administration of sulfadoxine pyrimethamine, amodiaquine, to children 3 to 59 months in Togo. These 4 presentations will be given here in this plenary room where we all currently are. There will be live English, French, and Portuguese interpretation for these. So if you're interested in this room, you will stay where you are. Next slide. Our second thematic room is on reaching the unreached. This room includes presentations on reaching marginalized forest goers with malaria prevention services using community engagement and client-oriented voucher mechanism, malaria prevention and care-seeking behavior among forest goers in Cambodia, and initial impacts of SBC for hard-to-reach gold mining populations in Guyana. Due to the technical limitations that we have with Zoom, this lightning talk room will be held in English only.
Thank you very, very much. I wish to thank everybody in our working group. Thank you for loving the working group, and thank you for joining our today's session. We still have a session tomorrow. The virtual forum is today's April. Thank you so much for the excellent moderation for this lighting moment at community level. Can I have my slides, please? I would like also to take this opportunity to thank Amy for the great Zoom technical support you've given us. I also want to thank the speakers of today, right from our CEO, who gave us very good opening remarks and also reminded us that malaria is bouncing back. We need to be tactical at how we are implementing our social behavior change, and also to ensure that we set out our strategic plans with SBC as a core intervention to make sure that we can get some resources lobbied for our interventions. I would also want to thank Abdel and Yusuf and Pauline for the insights in your presentations. They were great. And special thanks to quite a number of people who have turned up. We have our dear Dr. I know this, we have a doctor who usually supports our work for social behavior change. Dr. Stella Barbarora, I saw you in the group and said I should recognize you because you've always given us and furnished us with very new ideas in social behavior change. Thank you for joining us. I'd also want to recognize our predecessors, the leaders, Anne and Guda. You set a very good foundation for this steering working group. On top of that, let me thank the steering committee members and the secretariat for organizing this virtual forum. I must tell you that as this is being organized, it's like organizing a wedding. We always want to give you the best, and what you see is the best of a virtual forum. Next slide. Tomorrow, we have a very exciting agenda. And in that agenda, we have representatives of national malaria control programs. We have the M&E of our national programs and the program manager who will be speaking to us about prioritization of social behavior change in programs. We are also expecting a panel to discuss to us about the RTSS in the vaccine rollout. also look out for that. Please be interested in joining us. And we shall also have our lighting moments like we have had today. We've had 2 sessions of Breakaway, and really there's been so much to learn in those sessions, and we can duplicate them in our countries. Finally, we will host 3 more rounds. As you can see, we shall have the community and faith leaders. We shall have mass media for malaria SPC, and the health provider, behavior change and service communication. Look out and make sure that you be with us tomorrow as we wind up our steering committee virtual meeting this year. The Secretariat will send an email to you later in the day on a few take-home messages for day 1. Also look out for that on your emails. And in the meantime, please join the membership on Springboard to keep the conversation going on. We need you, we love you. Actually, like today, if we are meeting physically, we were supposed to have taken a picture with the CEO. But as you can see, we are a growing team. We've been so many on the call. About 250 members have attended today's call. Thank you so much. This is our baby, and we need to love it so much to make it grow and grow and grow. Lastly, with that, I want to close today's virtual forum. Thank you so much for joining us. We will meet tomorrow, same time the call started. Please be there joining the Zoom meeting tomorrow so that we conclude our virtual annual meeting. Thank you, and I wish you a very good morning or a good evening wherever you are. We love you. Thank you.